So let's start with some of the basics, if you don't mind, Adam. Let's talk a little bit about adrenaline, how it works, and how it helps anaphylaxis. Some of the questions we often get as well is how quick does that adrenaline kick in?
Yeah. So I think it's always really important to understand how and why the medicines that we have work, even for the people that are carrying them. And I think the place to start is what's happening when you have a bad allergic reaction. Now, thankfully, most allergic reactions are mild, hives, itchiness, maybe a little bit of lip swelling, and you can take antihistamines and that will settle things down. And what's going on here is that your body is releasing histamine in response to the exposure to the allergen. But sometimes these reactions do become more severe and they can progress really quickly. And the things that we really worry about in a severe allergic reaction, so what we describe as anaphylaxis, are symptoms in your breathing or symptoms with your blood circulation. And essentially, it boils down to two problems. The first is the effect that having a reaction can have on your breathing is that it can tighten up your airways, making it harder to breathe, and that will cause wheezing and chest tightness. Or the effect it can have on your circulation, which is that it causes the blood vessels to relax a little bit, which widens them and drops your blood pressure. And that's dangerous because it means you can't get enough blood to the things that really need it, like your brain and the rest of your heart, for example. So helpfully, what adrenaline does very, very effectively is it reverses those two things specifically. The action it has on your airways is it forces them open, and the action that it has on your blood vessels is it tightens them up, what we call vasoconstriction, and that essentially puts up your blood pressure. Now, there's a load of other sort of peripheral things that will do, like increase your heart rate, which means that more blood gets pumped around the body more efficiently. But it's those two sort of key things, forcing your airways open, bringing up your blood pressure, that are the really important things. There's two other really important things to know about adrenaline. The first is that it works best given as quickly as possible. And that's why we have people carrying adrenaline around with them, because it's worth having it early, because that means you get much better outcomes. It sorts your reaction out really quickly. And the other really, really important thing to know is that given through that muscle route injected into the muscle, it's really, really safe. And that means that you can say confidently to people, if you're not sure if your reaction's bad enough, just give it, because there's no consequence that you have to worry about other than you're going to need to go to the pharmacy and get a replacement for it. There's no consequence to giving it if it wasn't really necessary. So we always say to patients, if you're not sure whether your reaction's bad enough, just give it. Or indeed, you could say, well, when you're starting to think, is this bad enough to need adrenaline, is probably the right time to start using it.
We do hear that some people say, well, I've never had anaphylaxis and I've had the allergy for years, so I don't carry my pens anymore because I've never had anaphylaxis. But as you said, you just never know because of all the other cofactors that are involved when you might have
Well,
a serious reaction.
yeah. One of the things I hear loads in clinic, and I do my best to pick patients up on this when they say it, is they'll often say, well, I've got a mild nut
Mm,
allergy, or I've got a mild this allergy. And I would say, you haven't necessarily got a mild nut allergy. What you mean is that you've got a nut allergy and your previous reactions have been mild. And it's subtly but importantly different, because what it means is that subsequently in the future, you could still have a severe reaction. Similarly, you'll never hear two allergy doctors when they're talking to each other referring to a patient as anaphylactic to peanut. And I hear that a lot in clinic. People say my child is anaphylactic to. What they mean is they've got a peanut allergy and in the past they have had an anaphylaxis. In fact, they don't always mean that. Sometimes what they mean is my child's got a peanut allergy and their allergy test was really big, and somebody has told me that that means they're going to have anaphylaxis, which it doesn't mean at all, because the size of your bump on a test is not a measure of severity. When allergy doctors are talking to each other, they'll say somebody has a whatever allergy, and in the past they have had, or they have a history of anaphylaxis, and that does mean that that person is more likely to have another bad reaction in the future. But it doesn't mean that they will do. Subsequent reactions might be mild, in the same way as somebody whose previous reactions have been mild might then go on and have a severe reaction. So it's really frustrating that you can't do what everybody wants us to be able to do as allergy doctors, which is say, okay, you guys are high risk, that 5% of patients. So we're going to really focus on you and make sure that you are all over this and are really, really careful. And the rest of you, the other 95%, yeah, you're not going to have a bad reaction. So don't worry too much, and, take your EpiPens if you remember, but don't worry, worry so much. We just can't do that. For the
Mm.
overwhelming majority of patients, we have to say, look, you have an allergy, and unfortunately, there is an unpredictable, albeit small, risk of you having a severe reaction in the future.
So we often hear uncertainty around who can actually give adrenaline in an emergency. So, for example, do you need the person's consent? People ask a lot, or a parent's consent. If it's a child at school, does a teacher need parents' consent? And Simon and I were actually at a university earlier this year where they had, where a student had said they'd been told that they aren't allowed to administer adrenaline without someone's approval, which is quite concerning. So, Adam, do you mind just clearing this up for people listening? In a real life anaphylaxis situation, can adrenaline be given by anyone to anyone, or does it legally need authorization from a parent or a healthcare professional?
So I think there's a moral question and a legal question there. I'm probably better qualified to give advice on the moral side than the legal side, but in my mind, I don't think there are really any exclusions here. So, for example, specifically, and there's now guidance from the MHRA, the medical regulator, about this, for example, in the school setting, because when we had that real victory in 2017, we were able to get these spare pens in schools. So it meant that schools could have generic pens for anybody that was having an allergic reaction. The understanding is that that was exclusively for people who had a diagnosed allergy, who had had parental consent that their child could be administered this spare pen if for some reason that child's own pen wasn't available. And very quickly, of course, the obvious questions came up. Well, some kids have their first ever allergic reaction. They find out they're allergic by something that happens at school. And if they have anaphylaxis, are we really saying that the school can't use their spare pen on that? Or what if a child from another school's visiting, or a member of staff has a bad allergic reaction? They don't have these signed emergency plans in place. Can you use it on them? And the answer from the MHRA was clarified, and it's clearly yes, you can. And
Mm.
I would argue that, you have a bit of a moral obligation. There was I obviously won't mention names, but there was an inquest I was involved in as the expert witness, and there was a scenario where a child was having a severe allergic reaction. They, as it happens, their own adrenaline pens that were kept in the school office had gone out of date, and there were other children's pens that were in date. And there was a reticence to use other children's pens because they were saying, well, they hadn't been prescribed for them. And the MHRA will come back and say, no, you cannot use the, medicine that's prescribed for somebody else on a different person. And the analogy I raised there is that's a little bit like saying a kid has come into your nurse's office at school and they're on fire, and everybody's got a bucket of water with their name on it. And it turns out that his bucket of water is empty because it's run out. Are you really going to not treat that child that you can see is having a severe allergic reaction with the bucket of water with somebody else's name on it? Because that child might run in 5 minutes later also on fire and you don't want to have used it. You have to use judgment there.
Mm.
And for me, I think it's a pretty straightforward call. Similarly, you hear horrible stories about people who have taken themselves or their child with having anaphylaxis into a pharmacy and said, we don't have EpiPens or our Jext with us. Can we use yours? And the pharmacist will say no, because, somebody needs to prescribe it. It's a prescription only medicine.
Yeah.
And actually, if you look for legal precedent here, and I'm not a lawyer, so I think I have to put a disclaimer. I'm not giving anybody legal advice,
Yeah.
but my understanding is very much that under sort of, the Good Samaritan principle, there has never been a precedent for somebody in good faith trying to treat somebody to save their life, doing anything really, having a legal consequence after.
Mm.
So, whilst I think we always need sort of, the lawyers to give us, the definitive answer. For me, if you've got somebody with anaphylaxis and you've got adrenaline, you need to be using it.
And does it really matter that the adrenaline the pen goes in the thigh? Does it matter that it's in the same thigh?
There's a bit of history here. So traditionally, this was never really sort of, raised. We know that about 10 to 20% of people who use their first shot of adrenaline won't get complete resolution within the 5 minutes, and so will need their second one. And whilst the overwhelming majority of the times the ambulance will be there in order to administer the second one, it won't always be. You can't rely on it. So hence we have people carrying two. It's not because I think, as most people imagine, that there's a good chance that the first one will misfire or won't work properly, or they're very, very reliable devices, but you can give it properly, appropriately, and it just isn't enough, and so you might need a second one. So this issue came up of, well, is it appropriate to give it in the same thigh or does it need to be the second thigh? And this actually came up specifically in an inquest. And the expert witness at the time had said, well, maybe we'd have got a different outcome if it would have been given in the other thigh rather than the same thigh. But I think on reflection, whilst superficially that feels like sensible advice, the reality of it is that the effect that you get when you put adrenaline into the muscle is, as I mentioned earlier, one of the important things that it does is it tightens up your blood vessels, and that, of course, if you've injected an area with adrenaline, the blood supply won't be as good in that area because you've tightened up the blood vessels, and that means that if you then put another adrenaline injection in there, maybe it won't circulate around the body as quickly because it's not getting quite as good a blood supply. But in reality, it would require you to give the second shot in an identical position to the first one, which is impossible pretty much to do because they're tiny needles and you just wouldn't, even if you were trying, be able to get it in exactly the same spot. We also know that the studies that have looked at how effectively adrenaline is taken up and distributed in the body have generally used the same thigh to give that second injection and not shown that it's a problem. So there's actually no evidence that that's an issue. I think for me, because this has sort of got out there, what I've found is that when, for example, on social media, I've talked about using your adrenaline pens, my priority has always been keeping things as simple as possible, which is, i.e., as little things to remember. So for me, the important thing is give your adrenaline as soon as you think you might need it and give a second shot 5 minutes later. Don't complicate it by adding in the issue of, but it needs to be in a different thigh, especially when there's no evidence to support that. And just to be absolutely clear, our national guidelines, which are very, very, very carefully evidence-based, do not recommend the need for you to use a different thigh. They've acknowledged that there's a concern has been raised, but said there is no evidence to support it, so they don't advise using a different thigh. What I've found when I've talked about that, I get a load of responses saying, this guy doesn't know what he's talking about. This advice is dangerous. He's not telling you that you have to use the other thigh. So I've sort of taken a view.
Oh, do we? Don't worry. I think we do.
That we will better just say use the other thigh because my fear is that somebody will think, oh, wait a minute, I'm not going to pay attention to this advice because all these people are saying, well, it's not the right advice. So can I believe anything he's saying? And hence it's a pragmatic, and we could talk about this for a long time about what the rights and wrongs of it. But so I'll often just say, ideally, give it in the other thigh. But I'm saying it through gritted teeth because I'm adding another instruction, another complication that I don't believe is actually making any difference to outcomes. And if you challenge people on saying, well, why do you so vehemently, passionately say, you've got to tell me, where does this come from? It's just one guy in one inquest coming up with well, maybe the reason things didn't go as well as they should was because of this. But actually, when you just passionately just look at the breadth of the evidence, there isn't really anything to support it. And that's why it's not in the guidelines.